Hey guys, it's Olivia. Welcome back to our endocrinology chapter. In this section, we'll be covering 5 alpha reductase deficiency. 5 alpha reductase deficiency is autosomal recessive, and if you remember back to our pathway, 5 alpha reductase is an enzyme that works right over here to convert testosterone into dihydrotestosterone, DHT being that more potent form of testosterone that is responsible for a lot of the external virilization of external male genitalia. So in 5 alpha reductase deficiency, when we don't have normal levels of 5 alpha reductase, these levels are reduced. This is going to lead to decreased DHT as well, which will lead to a lot of the presentation symptoms that we see with 5 alpha reductase deficiency. Now, what is the presentation for 5 alpha reductase deficiency? Well, one important key differentiating factor between 5 alpha reductase deficiency and other forms of differences of sexual differentiation is the normal blood pressure. So because there's no disruption to this mineralocorticoid pathway in the zona glomerulosa, of course 5-alpha reductase is functioning over here, there's not going to be any dysregulation of our mineralocorticoids, and there's not going to be any dysregulation of blood pressure seen in 5-alpha reductase deficiency, which will differentiate this pathology from things like 11 beta hydroxylase deficiency or 17 hydroxylase deficiency, for example. Now, in XX patients, this presentation is often going to be asymptomatic and undetectable. And this is because XX patients don't really have a huge use for dihydrotestosterone to begin with. So the low levels of dihydrotestosterone aren't really going to affect their presentation as much. The more classic presentation that you're more likely to see on step 1 would be an XY patient who, due to this lack of dihydrotestosterone, which is important for the virilization of external male genitalia, may actually present with female appearing external genitalia, hypospadias, or micropenis. Hypospadias, of course, the failure to completely fuse the urogenital fold, so you may have urine dripping out of the bottom of the penis or a micropenis. All of these might be a result of low levels of dihydrotestosterone. However, while dihydrotestosterone levels are low, leading to disruption in external virilization of male genitalia, testosterone levels are actually going to be normal or increased. Think of this as kind of backing up behind the level of 5 alpha reductase, as 5 alpha reductase is not converting this testosterone into DHT. Because testosterone levels are going to be normal or increased, they're still going to act as they normally would on the Wolffian duct, leading to normal development of the male internal genitalia. So even though you might see a patient with female presenting external genitalia, they'll still have anti-Müllerian hormone to destroy the Müllerian duct, so they won't have anything like a uterus or ovaries. And of course, they will still have testosterone to stimulate the development of the Wolffian duct, so you should still see testes internally. The classic buzzwords that this would present with on a board style question are a quote unquote female patient, female in quotes, because of course we know that this patient is actually XY, virilizing once they reach puberty. So once this patient reaches puberty and the testosterone levels increase as they normally would around the time of puberty, you will start to see some of this virilization. And that is oftentimes when this difference of sexual differentiation is detected. Diagnostics: if this is an XY patient, you might see a female patient presenting to the office who then on ultrasound actually is revealed to have testes. And again, they would not have a uterus and would not have ovaries, but they would have these undescended testes internally. Further diagnostics: decreased 5-alpha reductase, decreased dihydrotestosterone. Normal or elevated testosterone levels, however, which is going to contribute to one of the key diagnostic tests that we use to detect 5-alpha reductase deficiency, and that is going to be the testosterone to DHT ratio. So while the testosterone to DHT ratio is actually decreased in a lot of other forms of sexual differentiation, in 5-alpha reductase deficiency, the testosterone to DHT ratio is going to be increased because, as we discussed earlier, you're going to have kind of a buildup of testosterone behind this blockage in the pathway, the decrease in 5-alpha reductase, which is going to the decrease in 5-alpha reductase, which leads to low levels of DHT. And this combination with elevated testosterone to decreased levels of DHT is what is going to lead to the elevated testosterone to DHT ratio. And that is going to be an important ratio for you guys to remember, as it's often used as a diagnostic test for 5-alpha reductase deficiency. Management of this difference in sexual differentiation is again controversial. There are surgical interventions which can be offered to alter the appearance of external genitalia if desired, as well as hormone replacement therapy, which can also be offered if this is what the patient desires. So that was a lot. Let's quickly recap what we talked about in this video. 5-alpha reductase deficiency leads to decreased levels of DHT. This classic presentation is going to be an XY patient who has apparently female external genitalia, but internal testes when tested on ultrasound. And then a great diagnostic screening test for 5 alpha reductase deficiency is going to be this elevated testosterone to DHT ratio. Now, how they ask you about this in a board style question? Well, something they might ask you is a 12-year-old girl is brought to the clinic by her mother for increasing acne and body hair. The patient has not reached menarche, breast development is Tanner stage 1. Pelvic ultrasound reveals the absence of a uterus, but what appears to be bilateral undescended testes. What are the expected levels of estrogens, testosterone, and DHT in this patient? Okay, so the question presents us with the case of a 12-year-old girl. However, the presence of testes on ultrasound would actually indicate that this patient may be XY. The increased acne and body hair noted by her mother to be so pronounced that she brought this patient into the clinic could also be signs of virilization around the time of puberty. Remember, increased testosterone in patients with 5 alpha reductase deficiency around the time of puberty may actually lead to some virilization in these patients. So this definitely seems like a case of 5 alpha reductase deficiency. And then the question goes on to ask us, what are the expected levels of estrogens, testosterone, and DHT in this patient? And we know from our testosterone DHT ratio that our levels of testosterone are either going to be elevated or normal. We know this because the synthesis of testosterone is going to be unaffected in this pathway. However, because 5 alpha reductase is deficient, these levels of testosterone may actually build up, so that we may have elevated levels of testosterone. Additionally, we know that levels of DHT are going to be decreased. That is what creates the difference in sexual differentiation presentation in 5 alpha reductase deficiency. And then finally, estrogens are not really impacted by this deficiency of 5 alpha reductase. Aromatase is still the enzyme responsible for converting some of our androgens into estrogens. It is functioning normally, so you're more likely to see elevated or normal levels of estrogen in 5 alpha reductase deficiency as well. That's all I have for you on 5 alpha reductase deficiency. I hope this video was helpful, and I'll see you next time.